Hi, everybody. Welcome to Metabolic Dysregulation. We are going to start diving into obesity, metabolic syndrome, and diabetes. These are very interconnected, and you'll see a lot of overlap between them and how they're all very connected and related. After we talk about some of the pathophysiology, we're then going to dive into some of the treatments, and that'll be, of course, nutrition, exercise, and mind-body treatments or therapies. We're going to start by talking about obesity, and I'd like you to kind of keep that psychoneuroimmunology lens on as we go through this material. Here are just some resources for you, again, for you, for your clients. Some of the trends, of course, 97, we saw 19.4% of the US was obese. 2017, 31.4% were obese. And diabetes from 5.1% in 97 to 9.5% in 2017. And there's clearly an association between these increasing trends. When we look at obesity, we look at the fact that it increases a lot of risk factors. So of course, coronary artery disease, hypertension, dyslipidemia, stroke, diabetes, some types of cancers like colon cancer, endometrial cancer, postmenopausal breast cancer. We see more gallbladder disease and gallstones, osteoarthritis, gout, breathing problems like asthma and sleep apnea. We see more pregnancy problems. Polycystic ovarian disease, we see more depression, as we've talked about already quite a bit. Some additional cardiovascular disease risk associated with obesity is angina, so that chest pain, non-fatal myocardial infarction, sudden death, stroke, congestive heart failure. There is some controversy with regards to mortality and the association with obesity. There are some studies that have been carried out over quite a long time, 15 years, over 15 years, that show increased cardiovascular disease, morbidity, and mortality in both men and women. So it's thought that there is a link. Here's a list of some altered physiological responses that we see in obese individuals. Of course, insulin, fasting insulin is increased. We see increased insulin response to glucose. We see decreased insulin sensitivity, decreased growth hormone response to insulin stimulation, increased adrenocortical hormones, increased cholesterol synthesis, and decreased in hormone-sensitive lipase. So there's lots of changes that are leading to dysregulation or as a result of dysregulation. So what's causing obesity? Well, here are a few of the possible etiologies. Hypothalamic could be issues with the hypothalamus if it's not responding properly or producing chemicals or responding to different appetite hormones and a number of different things. Of course, endocrine, genetic, drug-induced, could be nutritional, physical inactivity. Now, of course, we could probably throw the gut into this picture as well. There are multiple studies that have looked at the gene and obesity connection. Is it passed down? And we know that genetics affects an individual's susceptibility, absolutely affects the individual's susceptibility for obesity, but our genes are not our fate. Our genes are not our fate. They may increase our risk, but they are not necessarily our fate. So we're going to talk a little bit more about epigenetics. You might want to look at it this way. Our genes load the gun. They load the gun, but it is our lifestyle that pulls the trigger. Our lifestyle pulls the trigger. And a lot of this is through epigenetics. So we're going to talk just a little bit more about what epigenetics is. What it basically means is above or on top of genetics, epi meaning above or on top of, so on top of genetics. And basically these are modifications to DNA that turn genes on, turn genes off. So I mentioned this a few times, or even think of that dimmer switch. And so these modifications affect how cells read genes. And research shows the idea that genetics and environmental factors, they interact. So genes and environmental factors interact, and that influences biological makeup, predispositions for diseases. So when you think about nutrition, for example, you know, these components are coming directly into the body and they are interacting, right? So exposure to environmental factors. Now, it could be diet, as I mentioned, it could be exercise, it could be chemicals, smoking. Throughout all life stages, even in the womb, they alter gene expression. So environmental factors, they alter the cell's DNA in ways that affect gene activity. And this makes people more or less susceptible to developing diseases later in life. And that includes, of course, things like obesity. So we know through some studies in animals how diet specifically affects offspring. So this is really cool research. This is from years ago, but it's really, really cool research. What they were looking at was this specific type of mouse that you can see on the left. That's the mother. And this is a yellow agouti, and they tend to be bigger. You can see in the image there. And basically what they're doing is they are altering the diet. So the researchers were looking at that gene environment kinetics connection, specifically that gene diet interaction and how changing the diet affected gene expression. And with that change in gene expression was a change in the offspring. So what happened as the pregnant mother was fed a diet that was supplemented with, it was rich in methyl donor groups, then what happened to the offspring was they became lean, they became brown, they had a longer lifespan, they were healthier compared to when the pregnant mother was fed the regular mouse food. They stayed more like the mother. The offspring stayed more like the mother. They were yellow, they were more obese, they had a shorter lifespan, they had more disease. And so by changing the diet, by changing through epigenetics, changing that gene expression, they actually created a healthier mouse, different from the mother. Now we know that what we do when we're pregnant makes a big difference, and it's not just the female being pregnant. Of course, the male has part in this too, but it's not even just what the mother does, but also what the grandmother, what the grandparents did that can affect the offspring. And this is just an interesting flow chart looking at when we have maternal overnutrition and obesity. And you see so many women, and I've had so many friends do this, that were really healthy, really paid attention to their diet. And then when they got pregnant, it was like a free-for-all. Like, I can gain as much weight as I want, I can do whatever I want, I can eat whatever I want. And really, that is the time we need to be healthiest, because it affects our children, it affects our offspring, and again, what affects our next generation as well. Not just our immediate offspring, but our grandchildren are affected by what we do. What I did when I was pregnant not only affects my kids, my girls, but it affects their children as well. And you can see in this flow chart some of the information we see. Okay, weight gain, insulin resistance, diet. Those affect the mother. So when we have overnutrition and obesity, you can see this drop down here. We see going from the left, abnormal placental function. Of course, being obese really affects even the safety of the pregnancy. We see the next one is reduced skeletal muscle mass function. So the functioning is not optimal. Adipose tissue proliferation and hypertrophy. We see impaired pancreatic beta cell function. Liver, fatty liver, that non-alcoholic fatty liver, which we'll talk about more. Impaired vascular function, hypertension, hyperphagia. So we're changing physiology, we're altering everything. We increase insulin resistance. If you see how it just funnels down, we increase insulin resistance, and then boom, offspring obesity and metabolic disorder. That's what we're passing down. So again, our choices, my goodness, our choices make a difference. They make a difference. It's more than just that energy balance equation. You know, we always talk about energy in versus energy out, and yes, this is important, but it just isn't the whole picture. There's so many other things going on besides just how many calories we're consuming and how many calories we're burning. This is a beautiful diagram. I love this. This is from a very recent article. I loved this flow chart, and I'm going to be talking about each one of the different concepts that are within this. And stress is at the beginning. You probably should have made the stress box big because it's such a big driver in obesity. And so from the cognitive, the physiology, behavior, and biochemistry, stress is a major, major player. Of course, we see that stress can affect that cognitive function, self-regulation, and of course, then we see these bidirectional relationships, not just bidirectional. All of these boxes are connected in some way, but we know that the cognitive can affect the physiology, of course, the HPA axis, reward circuitry, that brain reward pathways, the microbiome. These are all going to affect our drives to eat. So stress is instrumental in this. Of course, the biochemistry, we've talked a little bit about leptin and ghrelin, neuropeptide Y. These are all hormones involved in appetite control. And of course, those are going to be altered by physiology, and they're going to alter cognition. They're going to alter behavior. And behavior, of course, eating, physical activity, and sleep. If we're eating too much, if we're not exercising enough, and we don't sleep well, that's going to affect all of these variables also. And of course, all of this together, all these interactions among all these different systems is increasing the risk of obesity. One of the other things that's added into this diagram here is weight stigma. And that's another piece of the pie that we don't talk about a heck of a lot, but that certainly can be feeding into that stress system as well. So overweight and obese classification. So what is considered overweight? What is considered obese? Here, of course, is just a BMI chart that you've probably seen 3 million times. But we know, of course, we have these anthropometric measurements like body mass index, which is the body weight in kilograms divided by meters, height in meters squared. And it's a rough estimate of body composition. I think it's a great tool. It's great for at least classifying and getting some idea of where somebody falls. Of course, you know, it doesn't tell us everything. It's not telling us about body fat. It's not telling us about lean tissue. It's not talking about body composition. And we know that it's really that fat mass that's getting us into trouble. It's not just the weight. It's really the composition and where that body fat is falling. Because there are certainly people that are going to fall way out of these ranges if they're very muscular. Like my husband would never fall into the normal weight category because he's very dense. He's got a lot of muscle. And so, you know, for athletes, you know, it's like a height weight table. You know, it's obviously similar to that, and they just don't fall within those normal categories. So this is, of course, we want to look at body composition. So here we can see some other measurements. Adding in the waist measurement is really valuable because, again, we know that a lot of the risk comes from that visceral fat in the abdomen, the deep belly fat. But here are some of the classifications of BMI. Of course, we have underweight is less than 18.5, and this is not healthy. We know that there are health risks associated with being underweight, both emotional as well as physical. Normal is considered a body mass index of 18.5 to 24.9. Overweight is 25 to 29.9, and obese is 30 to 34.9. And then, of course, we have different stages of obesity. We have stage 1, 2, and 3. And, of course, the numbers are going to just continue to rise from there. It's frightening when you look at some of the statistics on the extreme obesity end and how those have significantly increased over the years, putting people at a lot greater risk, of course. Now, I love the waist circumference. You could do waist to hip ratio too, and I think I've got a slide on that as well. But we know that as that waist circumference increases, if it's optimal, less than 40 inches for a male, 40 or less. For a female, less than 35 inches, 35 or less, I should say. And we know as we start to push above those values, we're at increased risk of things like diabetes, hypertension, cardiovascular disease, among many other chronic diseases. So one of the things we want to look at is body composition. If we have the opportunity to, we may not have, the equipment needed to measure body fat percent. And that's okay. We can still use BMI. It's still a good indicator, but there are so many home models now, bioelectrical impedance models. They're not perfect. There's some error rate in those, but they can still give us an idea of where somebody falls. You have to have empathy for the people that you're working with. And not everybody wants to get on a scale, and not everybody wants to measure body fat. And we need to respect and honor what somebody needs. And but it's still, it is really nice to see. I love measuring it personally, but we want to look at again, the body fat, because it's so instrumental in looking at those risk factors. What we have on this slide, of course, we know that it's positively correlated or associated with blood pressure, cholesterol, that's LDL, that's total serum cholesterol. That's also the ratio of the total serum cholesterol to the HDL cholesterol. Hemoglobin A1C, which we're going to talk a lot more about today, or in this first lecture, is also associated with elevated body fat percent. So looking a little bit more in depth at what body composition is, of course, it's a two-compartmental model. We've got our fat-free mass, which is basically everything that's not fat. So we have, with our fat mass, we have essential fat, and we have non-essential fat or storage fat. Our essential fat is or total body fat is the essential plus the storage. And that essential fat is found in marrow, it's found in, of the bones, the heart, the lungs, the liver, spleen, so organs. We need that essential fat. We don't survive without it. I mean, we've got to have essential fat, and it's pretty small, but it's necessary for physiological function. So, I mean, just think about your nervous tissue. Your myelin sheath is, wrapping around your nerves is, there's lipid in there. So essential fat for men is considered 3% of total body weight. For women, it's about 12% of total body weight. So when you have people saying, I'm less than 2% body fat, well, that's not really a good thing. So here we have our storage fat. Of course, we have that subcutaneous fat that's a little bit more on the outside. So if you pinch an inch, you're going to grab that subcutaneous fat. So for a male, about 12% of total body weight. And for females, it's about 15% of total body weight. And then the visceral fat, when we look at that, of course, that's the fat that's causing us some real harm. And this is what's surrounding those organs. We know that it's associated with negative health effects like glucose intolerance, hypertension, dyslipidemia. And of course, that waist circumference, we can look at that body fat distribution. And of course, people that have more of that apple shape, body fat shape or body shape, they typically have more of that weight in the middle. So again, I already mentioned the waist circumference of greater than 40 in men. It's really greater than or equal to, and females 35. But that waist to hip ratio above 1 is when you're going to start having more complications. So looking at fat, obesity fat cell size versus number. We know that after the fat cells grow to a certain size, we start to get more fat cells. And of course, the more fat cells we have, they can grow and stretch and fill. So it's very detrimental to grow more fat cells. And we really want to prevent this. So we have about 25 billion fat cells in a normal weight or a healthy weight individual. and 60 to 80 billion in obese individuals. So you can see there's quite a big difference here. During weight loss, the fat cell size decreases. The fat cell doesn't go away. So we're not getting rid of the number, we're just shrinking them. So if we have more of them, then all they do is shrink. So it still makes it harder to lose substantial amount of weight. I mean, we can still do it, but it's just a little bit harder. So prevention really, of course, is ideal. That's why we say prevention is the best medicine. So with severe obesity, meaning body mass greater than 30 kilograms, due to increased number of fat cells, we see what we call hyperplasia. And then less severe obesity is due to an increase in the fat cell size. So again, that fat cell size will hypertrophy and it'll fill to a certain level. But once we start creating more fat cells, that's that hyperplasia. And we know that that hyperplasia is associated with greater risk. Here are just a couple of the methods that can be used to assess body composition. Of course, we have that hydrostatic weighing or underwater weighing. We have air displacement. I can never say this anymore. I used to be able to, but plethysmography. It's so hard to say. The bod pod. Always wanted to buy one of those when I was in grad school. The dual X, the DEXA. And then the DEXA is a great scan. It's expensive, and you don't always have access to these certainly not in health, gyms and stuff, but more medical centers. They're used a lot more in research. But we also have easy access to bioelectrical impedance analysis, or BIA. And again, there can be some error, about 3 to 5% error, although they've gotten better over the years. And then we have the skin fold, or the calipers, and we can pinch an inch. I have just a couple tables here that you can look at some of the ranges. The one I have on the left, I like just because it shows athletic, all the way through obese, so you can kind of see what some of the ranges are, or some ratings behind certain ranges of body fat composition. So for athletic, for a male, like 5 to 10, a female 8 to 15. For good would be 11 to 14%. For male, 16 to 23% for good, acceptable 15 to 20. For male, 24 to 30. For female, anyway, you get the idea. And then in the table on the right, these are based on age, which I really like too, because a lot of the people I've worked with are, except for the athletes I've worked with, I worked in cardiac rehab and I worked in weight management, and most of the people that I worked with were not under 30, and they were not athletes. So I worked with a lot of people over 50. So these are kind of nice tables to see based on age.